I guess one final question about the idea of potential recurrences, or recurrence that patients deal with, is there were a few questions, and I know I see questions generally on some of the support boards about going to your medical oncologist or going to some other specialist, and you've had the surgery already, you now have a recurrence, so you had a diagnosis of DPAM, you come back 6 months later, 8 months later, it's determined that you probably have a recurrence, and the advice from the medical oncologist will be to watch and wait and come back in 4 months or 6 months and let's see what had happened. And I guess I just throw that out there for a general opinion from you guys in terms of, is there an appropriate time to watch and wait versus is it more appropriate to think about your options more aggressively?
Yeah, it's a big question. I sort of tell you what we do. It's sort of tailored to the risk of things coming back again. In general, we get a scan on people 3 months after they've gone through this operation to sort of see what things look like, sort of as we call it a baseline scan. And I always stress to the patients that we're not looking for for tumor. It's sort of what your baseline is going to be, because everything's going to look very different after the magnitude of the operation. And our radiologists, or even though we've got a complete cytoreduction, they invariably, just because of the little bits of fluid that are there, will read recurrent tumor on a scan done 2 weeks, 4 weeks post-op, looking for post-operative issues. So I always tell the patient, we're just getting a baseline, and then we're going to compare scan number 2 with scan number 1. Don't panic if you're getting the reports and looking at them yourself. And then based on the risk, if we get the scan at 3 months and at 6 months and we don't see a change from 6 to 3 based on the risk of the disease, so for the less aggressive ones, the DPAMs will start increasing that interval to 6 months and then a year, just because of the concerns about excessive radiation. For the more aggressive tumors, we'll follow them more carefully. And the second thing we'll do is patients will have, hopefully we get all the tumor markers ahead of time, and then if there's what we call a good tumor marker, if it's very high and then it goes down to normal or whatever after, that's the one marker we'll follow, and we'll do that at a similar interval. In general, for the pseudomyxoma, if we're seeing something increasing in size, if it's very fast, within 4 or 6 months of surgery, obviously it's a big operation to recover from. It's not something we can put somebody through, I don't think, 4 months, 6 months later. That would be somebody we would suggest that they have an aggressive tumor, we're going to be treating with chemotherapy, or if it initially is DPAM and it comes back that fast, we think that's been misclassified, and that would be somebody we'd have our medical oncologist potentially see and treat. And then if we get out beyond a year or so, if we start to see things, they would be patients that we would consider for surgery again going forward, 1 year, 2 years, 3 years out. If things are starting to show up again, that would be somebody we would evaluate again for another operation based on the amount of disease there. I think it's a little bit different than some cancers. If there's one little bit of fluid that's increased a small amount, it's not something where any speck of tumor is something we immediately jump in on. It's not something that has to be dealt with immediately. I don't think of it as, is there something there? But again, if things are increasing in volume, it's not something where waiting a huge amount of time would be. Don't worry about it. Come back in 5 years. That's not. It's something we keep an eye on, and be thinking about an operation within the next months.
Like maybe a term more like active monitoring instead of watching.
Yeah, it's something that's going to, you're going to need to treat this at some point. It's not something you need to rush in next week for. It's something that you can schedule into your schedule.